are going to discuss Chapter 46, Part 1, Disorders of the Pituitary and Thyroid Function. First, let's talk about hypopituitarism. It's a deficient secretion of pituitary hormones. Consequences depend upon the degree of the dysfunction. Gonadotropin deficiency is absence or regression of the secondary sex characteristics. Growth hormone deficiency is slowed somatic growth. These are usually your short kids. Then we had thyroid stimulating hormone deficiency. That's hypothyroidism. And then we have corticotropin deficiency. This results in adrenal hypofunction. It's diagnosed earlier in males than females because they are referred for short stature. Causes are usually the pituitary gland tumor. Other causes can be infarction of the anterior pituitary gland due to sickle cell, CNS infection, tumors, cranial irradiation, brain trauma, chemo, psychosocial deprivation. Other causes such as familial short stature, hypothyroidism, Turner syndrome, constitutional growth delay, chronic renal failure, Cushing syndrome, Down syndrome, inborn errors of metabolism, severe cardiac, pulmonary, or immunologic or GI disease. So let's look at growth failure. When it occurs without the presence of hypothyroidism, systemic disease, or malnutrition, then you have to consider abnormal growth hormone, insulin-like growth factor. Not all children who are short have growth hormone deficiency. Sometimes it's just a constitutional growth delay, which is delayed growth beginning as a toddler and skeletal and sexual maturation that is behind that of most other children of that age. Typically, these children will reach their full adult height. There may be a family history of growth patterns like this. Okay, so when we look at the diagnostic evaluation, you're going to look at family history, growth patterns, and previous health status, physical examination, psychosocial evaluations, radiographic survey. A skeletal survey is done in children less than 3 to examine the hand wrist for bone age. Then we have endocrine studies. The amount of growth hormone varies in children, so they do some screening first with levels of serum IGF-1, and if it's abnormal, they will stimulate the release of the GH via medication and draw blood then. Then we have psychosocial dwarfism. It's a reversible condition in which severe emotional deprivation causes suppression of the pituitary hormone production, which causes the transient growth hormone deficiency. When looking at therapeutic management, treatment is directed towards correction of the underlying disease process. Replacement with growth hormone is successful in about 80% of the affected children. Therapy is ended when the growth rates are less than 1 inch per year. Girls typically at 14 years of age, boys typically at 16 years of age. So what is your job as a nurse? Well, you want to be able to identify and assist with the diagnosis. You're going to provide child and family support. You're going to have emotional adjustment of the child that you will need to assist with. There'll be preparation for testing and medication administration you'll be responsible for. And you're going to provide increased attention to the child during the testing. Okay, let's talk about pituitary hyperfunction. If there is an excess of growth hormone that occurs after the epiphyseal plates close, then instead of the bones growing vertically and in proportion, the bones will grow transverse. Children can be 8 feet or taller. The head overgrows as well as the lips, the nose, the tongue, and the jaw. Paranasal and mastoid sinuses, teeth, can become separated due to the enlarged jaw, and there is a disproportion of the face to the cerebral division of the skull. Well, I don't know if anybody remembers, but in wrestling, Andre the Giant, he actually was diagnosed with the pituitary hyperfunction. So, clinical manifestations, children have increased facial hair, thickened, deeply creased skin, and increased incidence of hyperglycemia and diabetes. It's usually diagnosed by labs, such as an increased level of growth hormone. It may show excess in other hormones too, such as the thyroid, cortisol, or sex hormones. Radiology studies, which will show a tumor in the brain, normal bone age, or enlargement of the bones or joint changes. Usually, treatment indicates surgery and radiation, or surgery and radiation, to destroy the pituitary tumor, or radiation to destroy pituitary tissue. At this point, they will need replacement hormones for the rest of their life. Continuing, we're going to talk about precocious puberty. Characteristics indicate appearance of secondary sex characteristics before the age of 8 in girls or before the age of 9 in boys. They'll have an advanced bone age, premature skeletal maturation. Kids seem unusually tall for their age. That also causes mood swings and emotional ability. Usually occurs because of a tumor. It can also occur after encephalitis, meningitis, abscess, trauma, or neoplasms. Look at box 46-4, page 1465 of your textbook. In about 50% of the cases, precocious puberty development stops on its own. If it doesn't, then it's treated with Lupron gonadotropin releasing hormone analog, which is very expensive. It slows prepubertal growth to normal rates. Treatment is discontinued at age when normal puberty changes are expected to resume. In both of these children, they are likely to have body image disturbance issues. They may need pre or post op care if there is a tumor removal. You want to teach parents and the child about the condition. Okay, so let's talk about diabetes insipidus. ADH secreted by the posterior pituitary gland. It basically tells the kidneys to concentrate the urine because water reabsorption is needed. Pathophysiology, let's kind of review that a little bit. It can be from ADH deficiency or idiopathic origin. There's not enough ADH, so the renal tubules don't reabsorb any water, which leads to the polyuria, resulting in dehydration. It occurs due to the lack of ADH, or the renal tubules don't respond to the ADH. Brain tumors are common causes of this. Other causes, such as brain trauma, CNS infection, neurosurgery. So think about it. So what happens? They will urinate a lot. So some of the cardinal signs are polydipsia and polyuria. In infants, there could be irritability relieved with feedings of water but not milk. Dehydration often occurs. It's diagnosed by reducing fluid intake with little or no effect on urine output. Treatment usually is daily hormone replacement, drug of choice, vasopressin, such as DDAVP, nasal spray or intravenous administration. Then there's also subcutaneous or intramuscular injection. The injectable form lasts 48 to 72 hours. It has to be resuspended in oil by putting it in warm water for about 10 to 15 minutes and then shaking vigorously before drawing it up. Must see small brown particles before you draw it up. Treatment is required for life. You want to instruct parents in the difference between diabetes insipidus and diabetes mellitus. Okay, let's talk about syndrome of inappropriate antidiuretic hormone. It's an excessive amount of antidiuretic hormone in the serum. So what happens? There's a failure of normal feedback loop from the hypothalamus, pituitary gland, and the kidney, which results in excessive secretion of the antidiuretic hormone, leading to water reabsorption despite the low serum osmolality, resulting in increased intravascular volume. It also causes suppression of the renin-angiotensin system. Causes can be CNS infections, brain tumors or trauma, pulmonary disorders such as pneumonia, asthma, CF, and in children receiving PPV. It's also caused by chemo and diuretics. So lab findings are high urine osmolality, elevated specific gravity, low serum osmolality, or low serum sodium or decreased BUN. So your responsibilities as a nurse: maintain fluid and electrolyte balance, Monitor level of consciousness, vital signs, intake and output, labs. Implement seizure precautions. Weigh the child to assess for weight gain. Give diuretics as ordered, and provide patient and family education. Let's talk about disorders of thyroid functions. Thyroid secretes hormones. In the thyroid hormone, we have T4 and T3, and then calcitonin. Thyroid hormone regulates basal metabolic rate. The function of T4 and T3 are similar. They're usually just lumped together as generic thyroid hormone for practical purposes. What do you have to build thyroid hormone? Well, you need iodine and tyrosine. The thyroid is the only endocrine gland with a storage mechanism for excess hormone. T3 and T4 are bound to a carrier protein and stay that way until they are needed, at which time they will unbind. Calcitonin maintains the blood calcium levels by decreasing calcium concentration. Parathyroid hormone releases calcium from the bones. Calcitonin inhibits the skeletal demineralization and promotes calcium deposit in the bone. Patients may have hypothyroidism or hyperthyroidism, and patients may have disturbance in secretion of TSH. So let's talk about hypothyroidism. It could be congenital or acquired. Congenital is caused by genetic mutation, either spontaneous or inherited. Hypoplasia or aplasia of the thyroid. There's a failure of the CNS and thyroid feedback loop to develop, or there is an actual iodine deficiency. Results in irreversible mental retardation, growth failure if it is not treated. Acquired, idiopathic or autoimmune thyroiditis, late onset thyroid dysfunction. There's isolated TSH deficiency due to hypothalamic or pituitary dysfunction. Could be exposure to drugs that interfere with thyroid hormone production, such as lithium. It could be caused by partial or complete thyroidectomy for cancer or thyrotoxicosis, or after radiation therapy for Hodgkin lymphoma or other malignancy. Rarely occurs from dietary insufficiency in the United States. We have lymphocytic thyroiditis, aka Hashimoto disease. It's the most common cause of thyroid disease in children and adolescents. Results in a goiter and occurs more frequently after the age of 6. Thyroid function tests are typically normal, although the TSH may be slightly or moderately elevated. In many cases, the goiter is transient and will regress spontaneously in a year or two. PO administration of thyroid hormone may be ordered to help decrease the size of the gland and suppress the TSH stimulation, but the disorder may be left untreated. If treated, monitor TSH levels periodically. If untreated, the child should be evaluated for symptom progression or regression periodically. Look at box 46-6 on page 1468 of your textbook. It is more common in girls than it is in boys. Okay, so let's look at some diagnosis manifestations. Congenital hypothyroidism is found on a newborn screening. They check the T4 and TSH levels. If TSH level is high, low T4 level, then the disease is from the thyroid, not the pituitary. Newborn symptoms can be long gestation, like greater than 42 weeks, large hypoactive infant, delayed meconium passage, poor sucking feeding problems, prolonged jaundice, or hypothermia. Symptoms in early infancy, such as a large protruding tongue, coarse hair, lethargy, sleepiness, flat expression, hypotonia, constipation. The good quiet baby, usually referred to. They might have myxedematous skin changes. They could have a goiter. Remember, hypo equals high TSH, low T4, and hyper equals low TSH. So make sure you look at some of the clinical manifestations, such as edematous skin changes, dry skin, sparse hair, and puffiness around the eyes. Look at box 46-5 on page 1468. Looking at treatment, it's treated with Synthroid. You must make adjustments in dose as the child grows. It's given once a day in the morning. You want to teach parents to check the pulse prior to administration, crush and give with a little breast milk for formula. Signs of overdose are rapid pulse, irritability, fever, weight loss, diarrhea. Signs of underdose are lethargy, fatigue, constipation, and poor feeding. Educate parents and the baby that the baby will need levels checked periodically, and by suppressing TSH activity, the thyroid will eventually go back to normal size. However, babies born with a goiter may need surgery. This completes Chapter 46, Part 1.